So thank you for joining us today and welcome. My name is Himani Sharma. I'm the program specialist with the Department of Health Policy and Management. Also, I'm the co-chair of our Committee for Equity and Inclusion. Our committee is dedicated to foster a culture that promotes equity, diversity, and inclusion, and we're really excited to be hosting the Grand Rounds this evening. Without further ado, I would like to pass the mic over to our student member, which is Nimra Rahman, to introduce our guest speaker for the evening. Nimra?
Our speaker today is Ashley Michelle Fowler. Ashley Michelle currently serves as the Administrative Program Manager within the Office for Diversity and Inclusion at the Mount Sinai Health System in New York City. She is a PhD student at Pacific University, and her research explores the barriers experienced by Black male trainees in medical school. She has over 15 years of experience and education in topics of diversity, equity, inclusion, and social justice and intercultural communication. Ashley Michelle earned a Master of Education in Interdisciplinary Studies and a Bachelor of Science in Public Communication with a minor in Community and International Development, both from the University of Vermont. During this session, please submit any questions you have during the presentation using the Q&A feature on the screen below on Zoom. Now, it is our pleasure to welcome Ashley Michelle Fowler.
Thank you, Himani and Nimra. It is an honor to be here. I'm going to go ahead and share my screen. I don't know about you all, but when I hear my bio, it actually makes me feel cool. I don't generally feel like a cool person, but I hear that and I'm like, she's pretty dope. I'm going to share a little bit more context about myself as we go on in our talk today. But I am hoping that you all are here for this conversation on diversity, equity, and inclusion in public health, something I'm very passionate about and very honored to be a part of this series. Before we jump right in, though, I know many of us are coming from other meetings, doing assignments, herding kids, whatever it is that was calling our attention. And I know we all have competing demands for our time. I am so thankful that you all are here and choosing to spend your time with me. And I want to just level set us and ground us a little bit so that we can enter this space with intention and clarity of mind. So I've got a little visual here if that's helpful for you, but I just wanted us to take some time and do some focused, intentional breathing so that we can really work to be present in this space and be aware of what is around us and what's going on and kind of bring our thoughts to center. So I'm going to go ahead and take a few deep breaths and hopefully this is helpful for you also. I do this because in a lot of our spaces, we exist as academics and we stay in very ethereal and intellectual spaces. And I find that in addition to those aspects of this work, that this really is feeling and intentional, soulful work. So I really think it's important that throughout our time, we're checking in with our bodies and understanding what cues it's giving us and using this tool or any other tool you have to kind of recenter as we go through this content. So I mentioned I'd share a little bit more about myself. So outside of my professional kind of criteria there, I am also an ethnically ambiguous, biracial, multi-ethnic, identifying as Filipina, French Canadian, Irish, and Italian. And I also identify as brown, a cishet woman who was raised in poverty and became the first in my family to graduate from college, the first to obtain a master's degree, and God willing, will be the first to complete my PhD with my anticipated graduation sometime in early 2025. I've spent my career working in various aspects of student development and student affairs in higher education. I've studied and practiced career counseling, and I've engaged in this work, as Nimra shared, for over 15 years. Some of my professional and academic interests include barriers to access, men and masculinities, Black, Indigenous, and people of color and first-generation college student experiences, overall well-being, and Native and/or Indigenous visibility and justice. To that end, I also want to offer a land and labor acknowledgement as we exist in space together, both virtually and physically. And so as we begin our time together today, I do want to acknowledge that the land that we occupy is stolen land that is the original homeland of Indigenous people who through deep ancestral roots continue to have meaningful connections to this land. I'm personally joining you from an area currently known as Manhattan, New York, which was once called Manhattan, and originally inhabited by the Munsee Lenape Wappinger people, or Lenape Hoking. I also acknowledge that this country was built with unpaid labor of enslaved people who were brought here against their will and subject to centuries of systemic oppression. In our work together, let's honor these members of our community and respect their trauma and resilience, dedicating ourselves to the work we can do together to transform our community and create a more just place for ourselves and future generations. And I share this because I really do believe that connection to land and space in the context of where we are and how we do this work is critical to us being able to do this work effectively. So during our time together today, I will spend some time defining diversity, equity, and inclusion. We'll explore the impacts of social determinants of health and health disparities, consider the role of the public health professional in engaging in this work, and then we'll have some time for questions at the end. So first, to define and kind of provide some level setting for us, I found some definitions of these terms through the American Psychological Association, and there are lots of ways to define, but I feel like these are really nice grounding ways for us to enter the conversation together. So first, diversity is referring to the representation or composition of various social identity groups in a work group, organization, or community. So simply by existing with one or more people, we inherently have diversity. And you see this image here kind of displays some aesthetic diversity, but inherent to each of us being individual, there is diversity. Building upon that, however, equity then involves providing resources according to the needs to help diverse populations achieve their highest state of health and other functioning. And I like this visual that's presented here because you'll see in the first visual, which is displaying equality, everyone has received the exact same bicycle. However, that's not as productive for the person who is a wheelchair user, the person that is far too tall for this bicycle, or the person that is far too short for this bicycle. So it really looks like in that first image, only one person is truly comfortable and having their needs met. However, with equity, we then consider what are the specific resources and the nuance to those resources that are required for people to flourish. And so in the second image, you'll see it looks like everybody has a bicycle that has been adapted to their individual needs and allows them to travel freely and in ways that are comfortable for their bodies. And then the term inclusion, this is where we're striving for an environment that offers affirmation, celebration, and appreciation of different approaches, styles, perspectives, and experiences. So again, simply just by existing in space, we are inherently diverse. But with inclusion, we're looking to really celebrate and honor those things that make us different and bring us together in community around those differences. So in the first visual, you'll see a number of very diversely colored and shaped puzzle pieces, but inclusion is what brings those puzzle pieces together. I know we have a number of public health experts on the call, and so just again to reiterate and make sure that everyone's got some shared understanding, I also want to define healthcare disparities. And healthcare disparities, as explained by Paula Braveman and Sophia Gruskin in their article, Defining Equity in Health, says that health equities systematically put groups of people who are already socially disadvantaged. So for example, by virtue of being poor, female, gender nonconforming, or members of a disenfranchised racial, ethnic, or religious group, are at a further disadvantage with respect to their health. So a healthcare disparity in general is really looking at the differences in health acquisition and healthcare access between these groups. And these are things that are preventable And, when we look at these various populations of marginalized groups and others that are not listed, certainly there are individual and unique healthcare disparities that emerge that, again, are preventable. And so if they are, then we want to look at, well, what's behind that and how can we do that prevention? And I imagine many of you all are familiar with this concept of the social determinants of health, but I think it's important to name that the social determinants of health include factors such as socioeconomic status, education, neighborhood and physical environment, employment, social support networks, as well as access to healthcare. So I think it's really important that we keep that sense of all of these factors that go into someone's overall well-being and health really broad to understand the context goes truly beyond the simple access to healthcare and the administering of healthcare. And addressing these social determinants of health is really important for improving health and reducing long-standing healthcare disparities. So we then want to look at the impact of the social determinants of health and these health disparities. It's important to acknowledge that some people actually mistakenly assume that health inequities are entirely from an individual's failure to take responsibility for their own health, but health behaviors are generally products of one's environment. So social or socio-ecological determinants of health contribute to different and preventable health outcomes, including mortality and morbidity. Health inequities, like health itself, are shaped by multi-level socio-ecological influences. These influences include healthcare and individual behavior, but those are also in turn shaped by the physical and social environment and the social and economic resources of individuals in a household. These four domains are influenced by macrostructural conditions that are set by society, and those include things like public policies, social values, spending, and more. The social determinants of health are complex, interrelated systems, and thus the causes of health inequities cannot be reduced to simplistic explanations. So it's really important that we scale out and not look simply at the individual and their lived experience and the choices they're making, but what are all these external factors that are also having significant impact. What we want is to focus on the role that bias plays within the larger web, which would play out in the social environment and health systems. We're not necessarily going to get into strategies for reducing bias or intervening in bias situations, because right now the focus is more on the why and why we need diversity, equity, and inclusion to fulfill the goals of this work and this field. But I think it's still important that we're holding space for understanding how we can reduce bias in the systems and how we can intervene when it's coming up. Another way of looking at this is that, several studies actually demonstrate that about 80% of a community's health depends on place-based conditions. So physical environment really has a huge impact on any individual's health and then the overall health of that community. And this includes things like access to parks, sufficient and quality education, air quality, housing and housing access. And so we think about some things like, how exercise plays a role, and access to care, transportation and access to it, food and the quality of the food, and information about how to eat nutritiously. But all of this is contextualized within a community. And so health really doesn't become just an outcome of healthcare or your genetics or the lifestyle you lead, but factors such as the ability to exercise, the level of pollution in your neighborhood, the quality of your education, and what type of employment you're able to hold are all shaped by the policies and investments in the physical environment. I want to spend some time looking specifically in the context of New York City, because many of us are working and studying and living here. And I think it's important to note that people in Manhattan actually have an average life expectancy that is 5 years more than people in the Bronx. So even within our own city limits, there are some significant inequities to identify and try to understand. We also have Black residents in the city who are twice as likely to die from heat stress as those who are white. And some of that has to do with structural healthcare, housing inequalities, and even things like the lower likelihood of living in a home with air conditioning. About 40% of people of color live in areas in the top quintile for national levels of fine particulate matter, which is compared to just 5% of the white population. Due to a history of policies that enforce racial and economic segregation, much of the region's low-income housing and communities of color are actually located near highways, transportation facilities, and other significant sources of air pollution. 49% of people spend more than 30% of their monthly income on housing. 30% is on the high end of what any good financial advisor would recommend is the percentage that you'd be spending of your income on housing. But almost 50% are spending more than that. This is actually the third highest cost burden nationwide. And this can have very serious public health impacts, including that cost burden families are actually at a higher risk for homelessness and are more likely to live in homes with health hazards such as lead, mold, and pest, because when money's tight, they may not have options for housing that passes code and has some of the kind of health factors that would support their good health. Their households also tend to have less money for health-related expenses, such as nutritious food or recreation. And so when they're living with most of their money going to housing, it's a lot harder to access really healthy food or even be able to do things like join gyms or get class passes when there's not much left over. It's also really important to name that adequate data on many health outcomes, especially for American Indian and Alaska Native populations, remain scarce and unreliable. And so we actually know that there are inequities in these communities, but there's so little data to demonstrate that's a disparity in and of itself. Also of note is that New York City is actually the largest metropolitan area in the country with the highest concentration of Native American or American Indian identified folks. So, I think a lot of times when folks think of Native populations, they consider very rural areas and reservations, and certainly the larger state and country has those, but there are actually a very high concentration of Native folks living in New York City compared to other metropolitan areas. And we don't even have good data on exactly what their lived experiences are. And it will be not much of a surprise to folks that the COVID-19 pandemic really revealed a lot of these racial and other cultural biases and really revealed a number of disparities unto us in this country. And that's inclusive of the fact that communities of color were actually experiencing disproportionately high rates of infection, and that there was higher reliance on public transportation in communities of color. And those communities tend to be disproportionately lower income households, which increase the spread. So we have a number of folks who were considered essential workers and were living in these communities with lower socioeconomic status and then still required to go to work. Of note, some of the essential work is in the higher paying end, like some of our careers in healthcare, but there were even employees who were required to go to places of work that include positions in restaurants, custodians, and other lower paying blue collar jobs. And what we know is that the overall use of the MTA actually went down dramatically during the peak of the pandemic. However, these essential workers were largely still relying on public transit, and the buses and trains in the city actually create the perfect conditions for high rates of transmission. So the folks who were still using public transit and were not able to work from home or have private transport were being exposed to the virus at much higher rates. Also of note is that in the initial years of COVID, it actually overtook cancer as the second leading cause of death in the region, just following heart disease. So this really had a significant impact on our community. And obviously those of us who were here at the time know that New York City was indeed the epicenter. And so while the entire city felt its impact, the impact was felt very disproportionately based on what neighborhoods you lived in, what job you had access to, and what your transportation options were. I also want to reflect on national disparities, and I am really eager for those of you who are choosing to do your work here in New York City and its surrounding area, but I recognize that folks may be drawn to other geographies and want to underscore that public health is incredibly necessary and important work nationwide. So on a larger scale, racial disparities in healthcare coverage actually persisted in the year 2021, where we saw higher uninsured rates for non-elderly American Indian or Alaska Native folks, Hispanic, Black, and Native Hawaiian or Pacific Islander people compared to their white counterparts. So even after an attempt at equitable healthcare access was passed legislatively, we still saw much higher rates of Black, Indigenous, and people of color being uninsured. Also noteworthy is that LGBT people were more likely than their non-LGBT counterparts to report certain negative experiences while they were getting healthcare, which included a doctor not believing that they were telling the truth, suggesting that they were personally to blame for a health problem, or assuming something about them without asking and or dismissing their concerns. There's a concept known as the trans broken arm syndrome. Some of you may be familiar. And this is this concept that a trans person could go to a doctor with a broken arm and somehow the doctor wants to connect it to their transness. And so we see this a lot, and there's a lot of literature and research about the inequities and the barriers that LGBT people face to access. It's also worth noting that people who live in high concentrations of poverty are at increased risk of poorer health outcomes over the course of their lives. So we see this both in our urban environment, but especially in rural areas throughout this country. So with all of this as the context, I then would love to explore the role of the public health professional. And again, with so much gratitude to those of you who are entering or currently practicing in this field, I think that public health has a real significant role to play in order to amplify the concerns that are brought up with these disparities and to build upon the work that's happening in the healthcare sector specifically. One of the ways that we can do this is moving beyond cultural humility. Now, there are 4 terms up here: cultural awareness, cultural sensitivity, cultural humility, and cultural responsiveness. And you may be familiar with some or all of these, but these are not synonyms and there are important nuances. And so I'd like to make a case for moving beyond cultural humility and getting us to a place of cultural responsiveness. So we start first with just a simple cultural awareness. And this is where we're just aware and mindful of similarities and differences that exist between people within groups, understanding the dynamics of power, privilege, and oppression, and just kind of having our eyes open to what's at play in the system. And that's a critical first step. But as we move beyond that to cultural sensitivity, we're then deepening our understanding and the ability to apply that learning to the practice and the work that we're doing. And we're not only aware of these differences, but are respectful of accepting of these differences, and that we're not making valued judgments based on whether these are good or bad, but we're just kind of holding space for the difference that exists. In cultural humility, we're taught to reflect and to become more deeply self-aware, to not make assumptions, and to really understand the ways that culture affects our language, beliefs, values, and so on. And we come to the work with this sense of we don't know it all. We're only experts on our lived experiences. And there's a deep curiosity and ongoing learning process that happens with cultural humility. And these first three are all really great foundational frameworks and ways to exist. But I would urge us all, and certainly within public health, to think of cultural responsiveness as the goal. And this is where we become not only aware of the cultural factors, but then we respond to them in an appropriate manner. We are flexible so that even when we don't know all there is to know about other cultures, because guess what? No one does. But we have the tools and skills to navigate difference, and that we can demonstrate respect, build on strengths of the culture, and attend to individuals based on their individual context, which is inclusive of their environment and culture. So I think, a really important place to start is by developing these skills to be nimble and flexible so that as we come across difference, we can be really thoughtful in how we engage with it. I also think community development has developed some really incredible frameworks and helped us think about how we can engage with our communities that we're working with in ways that go beyond deficit models. So I think traditionally community development has really taken this approach of understanding what's wrong, what problems exist, what's broken, and how we get to solutions and how we fix things. And it creates systems of dependence. It disempowers the people that we're trying to serve and support. And it even has this kind of condescending level of pity that is exhibited. However, when we approach our work with an asset-based mindset, we're looking at what exists and what opportunities are present and what can be expounded upon. And we're taking existing ability, capacity, capability, skill sets to build upon and to get beyond the deficits. It's also very empowering to the local community, and it is focused on giving control and kind of capability to the folks who are most directly impacted. And so I think that for the practitioner, it really is a humble approach in which we kind of understand our surroundings and work in partnership and collegiality, and even allow the folks we're working with to lead and helping them get to the solutions on their own with what they have. And then recognizing that if we are adding, it is at the behest of our communities and not something that we're imposing. So in asset-based community development, we don't want to assume that communities need us or the resources that we have access to, or that they need anything more than they currently have. They very well might, but we don't want to assume. We want to go in with an open mind and really take in the situation and understand directly from people impacted what the needs are. That allows any outside resources that do come in to be more effective, because the local community will have been mobilized, they're invested in the work, and they're helping to define and drive the agenda. There's also this internalization where we have a strong internal focus to ensure the primacy of local definition, investment, hope, and control. And we're really asking the folks we're working with to drive and define this. And it is a relationship-driven model. I think it's so important that folks really allow the relationships to shape this process. I often give the example of when I've done development work in contexts outside of the United States, there are times when meetings will get started hours after they are publicized. And for me, as somebody who values time and efficiency and just considers timeliness as a sign of respect, it can be very challenging to my worldviews and norms when folks kind of casually make their way to a meeting, but recognizing that culturally there are contexts there that make that an acceptable strategy, and that I need to check my own kind of biases and opinions and ways of doing the work in order to best serve the community. Similarly, I've been in meetings where the meeting cannot get started until every single person in the room has individually greeted every other person in the room. And you can imagine when there are 50 or 100 people at a meeting, that can take up a lot of time. But in these communities, that sort of that action is very foundational to relationship and trust building. And so I think it's really important to understand the context in which we're doing our work. Also, just want to say that communities are not always even aware of their strengths, and they're not used to focusing on their strengths, so they're often socialized into understanding what their problems are and being taught to mire in them and really trying to fix them. So this may even be a new way of thinking for the clients, communities, organizations, departments that we're all working with, and so helping them to see what their strengths are and to come from that approach, because it may not be a familiar muscle. One time I remember I was in a rural Honduran community and learned about some of their farming techniques. And I was so in awe of how they were able to do farming. And they had much older technology than the types of things that we would see in a lot of farms here in the United States. And we were, our group was just communicating to them like, this is so fascinating. And there would be so many people who would be excited to come and learn and understand their ways of doing things. And they were surprised because this was their average day to day. And for them, it was nothing noteworthy. And they were completely taken aback that people would come to pay and learn from their technology and their processes, right? And so just simply by being someone that's there that can hold a mirror up and reflect back to the community what their strengths are and what they have going for them can really be transformative. Really specifically, I believe that public health professionals have an opportunity to take action in a number of different ways. This list is not at all exhaustive, but I think I just want to encourage all of you in your work to really think strategically about specific outreach and education efforts for marginalized populations. And I think the beauty of this is that when we center the most marginalized of people, it turns out that everybody wins and everyone benefits. So sometimes folks see doing diversity, equity, and inclusion work as ancillary or special or an add-on to the work they're already doing. But this actually creates an efficiency in your work, because when we figure out what the most significant needs are within our communities, we're actually able to create systems that work for everybody. I also want to encourage folks to mentor aspiring public health professionals, including through the creation of pathways to the field. I know that public health already certainly has many different pathways, but at the end of the day, many of our public health professionals do not reflect the communities and the identities within those communities that they serve. And so I know that when I was a child, work in public health was not anything I was aware of, and it's certainly not anything I would have known to look for. And I think that each of you has an opportunity to be a visible presence, to support up and coming professionals, and to role model the nuance and excitement and diversity of this work. I also think that it's important that we stay advocating for meaningful policy change to mitigate the impacts of the social determinants of health. Because again, when we look at all the realms of the social determinants of health, it goes far beyond our hospitals and clinics. And I think that it's really important to look at what are all of the ways that our policies and practices and societal norms are impacting people's ability to thrive and be healthy. I also think partnering with and following the lead of trusted community organizations that are representative of the communities that you want to serve are so critical. There are so many studies and so much literature out there about times when professionals have partnered with local barbershops, local religious communities and places of worship, community centers, senior centers, and more. So I think really taking an in-depth ethnography of your area and your clientele and the work that you're trying to do, and figure out who are those key trusted partners in the community that can help you gain buy-in, but also help lead and demonstrate to you how to be most effective with the communities you're working to serve. Certainly, it will be no surprise to you that ongoing professional development and continuing education is critical to this work. I'll say again, I've been doing this diversity, equity, and inclusion work for almost 2 decades now, and it is rapidly changing and evolving, and the frameworks with which we hold space for different things have shifted, and the terminology. So there's really no limit to your ability to engage across difference and deepen your learning in those areas that you just have less experience. And lastly, I would love to introduce or reintroduce for some of you the iceberg model from systems thinking, which will help us to identify the context within which problems exist and help us get to transformative solutions. This is especially salient for me because I was recently talking with a public health student in a different program, and they shared that their teacher commented that places in the Bronx and Brooklyn that would be considered lower income, or sometimes maybe referred to as hoods, are dirtier and have more trash on the ground, and just have more of an issue with proper recycling and trash disposal. And the conversation was left there. And unfortunately, that was a very significant missed opportunity because the teacher did not share more about the context of why that's happening and what are the conditions that cause that. So folks may be familiar with the iceberg model, but essentially the idea of the iceberg is that there's what we see on the surface, the events or the kind of situation of what's visible to us. But most of what's informing that is actually underneath the surface, and we need to dig deeper. And so when there's the event, that visible piece, it may be this neighborhood has more trash on the ground. It may be, Black people are struggling with finding secure housing at higher rates than any of their counterparts. Whatever the public health issue might be, what I would encourage you all to do is to really think deeper. And so we first start by looking at the patterns and trends. So what are we noticing about not just this specific thing? So in the case of trash on the ground, are we noticing that there's a culture of most people in the neighborhood following suit? Is there kind of this unspoken rule that you just throw trash on the floor? Is there less frequency of receptacles? And is it harder for people to find places to dispose of their trash? Has there been education in the schooling environment to help people understand the implications, right? So we start thinking about what's going on around us. And then these underlying structures. So what is influencing those patterns? How does policy, distribution of resources, physical space, et cetera, align with this? So if we're noticing that more people are comfortable throwing their trash on the ground here than in another neighborhood, what could be behind that? And again, does it go back to the funding that's available to even place receptacles? Does it go back to the quality of education? And do we have educators who are informed on environmental justice issues that are able to teach the benefits of, avoiding littering? Are we creating situation where we reduce waste? Do we have systems where maybe stores aren't distributing bags as frequently, or there's less packaging on some of our food? But even deeper, we look at the mental models. So these are those conscious and unconscious thoughts or assumptions that are so deeply held and affect our sense of the world, and these drive behavior. So, are there concepts where, maybe the local citizenry thinks, well, everything's going against us anyways, and the conditions aren't great for our health. So what's one plastic wrapper on the ground? Is it that the politicians in the area don't necessarily believe in the self-efficacy of the local citizens to learn recycling and trash disposal? And so maybe they're not advocating for additional receptacles. Is it this kind of ignorance around what are the impacts of litter and trash and air pollution on my health, right? So what are those foundational things that are really informing this? And then on an even deeper level, looking at cultural and institutional values and what those core beliefs are, what those values are, and how they're embedded into everything that we do and kind of inform our worldview. So if you're laboring all day at work and working 16-hour shifts and don't have access to grocery stores with fresh produce, and you're just getting the quickest, easiest, cheapest meal that you can get, and you're scarping it down on your walk home before you have to do all your house chores, are you really thinking about the impact of dropping your trash on the ground, or does it not really rise to the surface? And so are you so steeped in some of these other issues and these health disparities that are created that you're not even able to come up to look at some of these larger contextual pieces? And again, are the folks who are responsible for legislating and policy making even believing in your ability to flourish in these conditions, or have they already written you off in your ability to be successful? So I think that iceberging the problems that we see and not simply recognizing what problems exist, but being able to do some more digging and get underneath the issue and really understand what are the greater conditions that are allowing for these problems to exist, and then coming at it from that asset-based approach to figure out what can we do. So what does this look like when we start ramping up the environmental education and we have qualified educators who are well funded to do the work to be able to let people know the impact? What happens when we increase the amount of receptacles in our communities? Do behaviors change? What if we add more funding and trash pickup was more abundant and more reliable, right? And so now all of a sudden, this simple kind of myopic story that was created about hoods being dirtier and having problems with trash, now all of a sudden becomes a very solution-based approach that may be transformative for our communities. But when we as professionals kind of reduce these problems and put the onus on the individuals, we're going to fail to see some of that. So I want to thank you all for being here and sharing in this space with me. I'd love to hear questions and comments and just better understand how I can support your ongoing work. I know we've got some Q&A coming through, but feel free to use that Q&A feature, and I'll stop sharing my screen so that we can enter that space.
Thank you so much for that really really impactful presentation. And I like the themes that were coming through. And I think one of the most important aspect of your presentation that I found was how DEI needs to be not an extra to the work that you're doing, but it has to be embedded in a lot of the work that we're doing. We have to really reflect on some of the policies and procedures that we're looking at and really implement the DEI work in an ongoing way and not as an add-on to the work that we're already doing. So thank you so much for your presentation. I'll give folks a few more minutes to ask any questions. I know I have one. We'll get you started on that. One of our attendees asked, what happens if all these great initiatives and or DEI programs are discontinued? The pending Trump administration is planning on disbanding all things DEI if elected back in office.
Yeah, it's a really great and important question, and one that we all need to be constantly reflecting on in doing this work and any of our work, because I think at the end of the day, there are already attacks on this work and it's already being dismantled, to be clear. So I think that in New York and New York City, we have enough of a buffer that it's not quite as obvious. But we have colleagues in other states around the country who have literally come to work one day to find out that their job no longer existed. Their office had been completely removed, and the work as it exists was not allowed. That being said, that's why I think tools like systems thinking and the iceberg model are so important, because regardless of the terminology and the exact way that we approach the work, I think we have an opportunity to really unearth what inequities exist and create programs and systems that work for everybody again. So when we center those marginalized experiences, we can create benefit for everyone. So, I think that when we look at our education system, right, we know there are significant inequities that exist for racially and ethnically marginalized groups and lower socioeconomic status students, right? And without even naming them specifically, we've seen some incredible examples of where equity has been able to champion all students. We have schools around the country now that offer free breakfast, lunch, and even snacks or dinner meals for students, regardless of their income status. And so by funding such a program, certainly the students who are most marginalized are going to benefit, but it doesn't hurt anybody to have access to extra food and extra, guaranteed meal. And so I think that we should remain mindful of the importance of diversity, equity, and inclusion. And there may be times when we are banned from using those words, those frameworks, or even specializing programs for specific populations. But I think that we can continue to understand what are the things that we can do to improve the conditions for everybody in our community, and know that the most marginalized people will win in those situations.
Thank you. Another question that we have is for your work at Mount Sinai. Are these particular challenges your office has faced and worked with, or innovations, tools that we could perhaps learn from here at CUNY-SPH?
Yeah, absolutely. Thank you for that question. I mean, at the end of the day, we are training scientists and doctors, and we are working with our patient populations. And these are issues that are just emergent always. And I think that we all have a responsibility as citizens of these communities to be engaged in the work. So I'm always very thankful for those individuals who explicitly choose to go into public health work. But I'm also just cognizant of the fact that each of us has a responsibility for how our communities shape up. And that is inclusive of issues like access to healthy and nutritious food. We know that we have so many food deserts in this city. And, what are we doing to be able to advocate for, farmers markets or, specialized produce markets to be able to come to our communities? And how are we educating people on how to eat on a budget? I know some grocery stores have incredible programs where they welcome customers to come in and they show them how to buy in bulk and some of the hacks that they can use in order to eat better. And so at Mount Sinai, I think we're certainly not immune, and the work of diversity, equity, and inclusion is under attack nationally. And that's coming in a lot of forms. So there are groups that are placing complaints with civil rights offices to have different programs investigated. There are attempts at legislation that's being passed nationwide, and some successfully, and others we're waiting on. And I think that there's just kind of a general resistance, and always has been, right? So the resistance to this work isn't new. I think some of what we're seeing unfold is a little bit more sophistication in how people are resisting or even attacking the work, but this is work that we're always doing. And so I think part of what we've done at Mount Sinai is make sure that the things we're doing are that we have good data, because I think that data is really critical. Some people really need to see the impact quantitatively and qualitatively, and so making sure that we're bolstering what we're doing with data that demonstrates success, right? And even data that creates the argument for the why we do this work. And then I think also it's about pivoting where necessary and just trying to be nimble so that we never forsake the work, but we do it creatively and in an evolutionary way that allows us to be able to continue to do it regardless of the attacks that are coming at us.
Thank you. Our last question. I've heard that some places are changing their DEI work in departments to culture and company culture work. Do you think changing the name could help the work continue to push forward, or should we continue to push the importance of using DEI terms?
Yeah, so thank you for that question. And again, there's this kind of evolution of it. And so in some areas, they are actually shifting language so that the work that they're doing is less explicitly diversity, equity, and inclusion. And there's kind of always been this, there's been a trend of that, I would say, probably for the past like decade or two, of people trying to come up with different ways to say this that are a little bit more palatable to maybe a resisting audience or a less informed. And so we see things like culture, we see things like inclusive excellence or belonging. And I really do believe words are powerful and that we should say what we mean and mean what we say. And I think that we need to continue to find ways to do the work that are supported and legal. And so, I think that there's room for the radical work that's always going to happen on the fringes, but for those of us who are working within systems and structures that we're trying to shift and dismantle and transform, that we need to be a little bit creative about how we do this. So I don't believe in watering down the language to the point that the work is now unrecognizable and diluted, because when we have these very real healthcare disparities, it's important to name that certain people are worse off than others and to create solutions to mitigate that. But at the same time, I don't know that martyrdom on the hill of specific terminology is the way to go either. And frankly, diversity, equity, inclusion is largely recognized, and these are words that are used quite frequently. But I think in a lot of ways they have become outdated, and that we need to think beyond just simply inclusion and this idea of like making sure everybody's a part of our communities. But how do we work towards justice? How do we work towards liberation? And those are bigger transformative conversations. So I guess I would encourage you all to stay strong and to do the work in ways that you're able to, and to really just understand your own level of comfort with how much risk you're willing to engage in, and and how you want to come into this work. But I would just encourage you all to reflect on how you make this a part of your work and put it in the fabric of what you do. And whether you are explicitly working in diversity, equity, and inclusion efforts, or it's just baked into how you exist, I think that at the end of the day, we really just need to serve the most marginalized among us.
Thank you for that. So our next question, thoughts of the common exclusion of Jewish people from DEI framework?
Yeah. So I think that, again, this is where some of the flaws of diversity, equity, and inclusion as a framework and even as terminology is that like so many other terms and strategies, DEI has been conflated with certain things that it is and is not. So I'll often hear the kind of the acronym or the terms of DEI, diversity, equity, and inclusion, conflated with work for people of racial, ethnic minorities. Sometimes diversity is limited just to race. And I think that those are false conflations, because the work of diversity, equity, and inclusion at its heart has always been inclusive of all people. So I am, I hold space for Jewish people who haven't seen themselves reflected in this work, because I think that when it's being done well and holistically, which is how I've always tried to do this work, that Jewish people are certainly a part of that, because I think diversity, equity, and inclusion work seeks to interrupt the discrimination and the violence against any people based on their identities. And so as we see this current rise of anti-Semitism, but also the historical existence of anti-Semitism, I think there's a lot of examples of solidarity between Black and Brown communities and white Jewish communities, but certainly there are some Black and Brown people who also identify as Jewish, right? And so I think there's been a lot of solidarity across racial and religious minorities and marginalized groups. And I think that the media and the larger society has kind of diluted that. So I would encourage folks to do some historical learning on the incredible solidarity of people working across difference, again, in interfaith work, in racial justice work, and religious freedom work, because there's so many examples of that. And I think we're being sold short in our society.
Thanks, Ms. Fowler. Our last question for the day. I'm a Black man looking to get involved in public health work and activism in a more robust way. I don't see myself reflected in these spaces despite years of community involvement. I'm not an academic, but a concerned Black man. Where do I fit in?
Yeah, this is such an important and incredible question. And it goes back to earlier where I was talking about creating pathways in programming, because there are so many marginalized groups and people with identities that do not see themselves reflected in public health work. And so I think it's incumbent on the existing public health professionals, regardless of their identities, to show up for and make space for people with different identities. But, I think that we all each have our own kind of entree into this. And so I want to commend you for doing this work and being involved in your community in spite of not being seen. And I think that the reality is, there's this idea of imposter syndrome where we kind of feel like we don't belong in a space, or we're not worthy or good enough or smart enough or whatever. And that's something I always like to combat, because imposter syndrome insinuates that we are experiencing something individually and internally that may or may not actually be going on. But the reality is that systems and structures were meant to be exclusive and built to be exclusive. So whether that's systems of education, of government, of healthcare, whatever systems we're existing in, were really built upon very exclusive practices and strategies. And so those of us with marginalized identities, I believe, are not actually experiencing imposter syndrome, but rather imposterism, because we are imposters in this space, right? Like there was a time when women were not allowed to attend institutions of higher education, and even times when they weren't getting K through 12 schooling, right? There have been times when Black people weren't allowed to attend the same schools as their white peers, right? And so I think that, even as I look at like the history of like the Mount Sinai institution, right? Like it was really designed initially to serve the Jewish immigrants that were being rejected otherwise and not taken care of and not served properly. So I think that for us to exist in any of these systems is radical. And I think it's going to just take a lot of determination and stamina and building a team of support around us in order to be able to navigate these systems and learn how they work and be able to flourish. So I would encourage you to engage in this work however feels good to you, whether that's through formal means, like participating in one of these educational programs, or, running for office, or community organizing. But even if it's just in constantly deepening your own learning and showing up for your sphere of influence, like I think really meaningful and powerful, life-changing conversations happen in places like churches and synagogues and barbershops and grocery stores. So wherever you have the chance to engage in this, I would encourage you to do that. But just know that your experience of not seeing yourself reflected in this work is not unique. And if you would like to be the trailblazer and create more visibility, then I want to empower you to do that. But if that feels like more than you want to take on, then just do this work in ways that feel authentic.
I think that's so important. Representation definitely is needed in a lot of spaces that we're doing our work in. So do you have questions? So I think we're going to do 2 more questions.
Yeah,
If you have time.
I sure do.
Do you have recommendations on how to get buy-in and involvement in DEI initiatives on campuses?
Yeah, I think a few things. One, I mentioned data earlier, and I am kind of a nerd around this stuff. So I love like research and numbers and stats and all that. And I get that that's not everybody's thing. But figuring out how you can contribute to the greater body of data to make a case for this, right? And you don't necessarily have to be very innovative in this. There's so much research and literature that exists that demonstrates why we need diversity, equity, and inclusion, what the benefits are, and how all of us are improved with diversity, equity, and inclusion in mind. The other thing I would say is like, you can I think that storytelling is really powerful, and so finding ways to tell the story in ways that people will listen. So some people need that like one pager of just like facts, figures, stats, data. Other people will be changed forever by just a relational conversation and development of a relationship that leads them to see things in new ways. And I think, some people are driven by money. So finding out what someone's motive is and what really inspires them and being able to speak in their language can help. But I think that ultimately, by each of us living authentically and being able to learn these skills about how to talk across difference and how to tell our lived stories and share our experiences is really how we're going to do that, because there's these attitudinal pieces that exist, and those are barriers, but then there's the systems and structures. And so while I believe that changing individual minds and hearts are very important, I also think that we need to examine our sphere of influence and figure out, what do we have agency over, what do we have control over, and how can we create change where we can. So if you're responsible for helping to draft a policy, do it with an inclusive lens. If you are planning an event, do it with an accessible lens, right? So thinking about, I may not be the leader or the head of an organization, but there are things that I do and choices that I have that can help people feel seen or help people feel excluded. And so how do I continue to make sure everything I do is through the lens of DEI?
Thank you. And the last question would be, a lot of the folks that are doing DEI currently are feeling a sense of burnout. What advice would you have for them, and also for your fellow PhD students that might be, experiencing some of the burnout from this kind of work too?
Yeah. Listen, the burnout is real, and I think we are not taught or equipped with how to resist burnout. And so, unfortunately, more of us get there than not. But I think that there are strategies that we can utilize that will help prevent it. One thing I would highly recommend to everyone listening, there's a book called Rest is Resistance, a Manifesto. It's by Tricia Hersey. And I think it is an incredible kind of strategy for reshaping our relationship to rest and imagining how we can be most effective in living the lives that we want, independent of the need to produce or kind of the temptation to be the most and do the most. So I think that really helped shift my thinking in a lot of ways. I'm a huge proponent of therapy, and so finding an inclusive and responsive therapist, I think, really can help sustain the work, and making sure that you are holding space for people and the problems of the world without taking it on. And that's really difficult, especially for any of you who identify as an empath, which I do. But I think that I've really had to learn how to like hold space for issues and not hold it all, because I think when I'm kind of internalizing it, I feel it in my body. And I really believe that this is very somatic work. And so being in tune with how our bodies are responding to things, what symptoms are emerging, and what are some of the things that our bodies are trying to communicate to us. Because, there's another book, very famous book, called The Body Keeps the Score. And a truer statement has rarely been said, because, our bodies do give us information. If you notice that you're constantly coming down with colds, or you have a cold that won't kick for 8 weeks, if you're in massive amounts of pain and your body's hurting, if you pass out at 7 p.m. and don't wake up till the next morning, like, these are ways that our bodies are telling us that we're depleted, we're exhausted, we need to rest. So I think trusting that even when we stop, even when we pause, there are other people that are doing the work, and the work will continue, and relieving ourselves the ability, or rather the need, to be like the hero or the martyr or the only one doing it. Because even when it feels like we are the only ones, and we may be in certain spaces, but we're not the only ones doing this work more broadly. And the best way we can show up for the work is in a sustainable, long-term way. We need each of you for the long haul. So do the things that double down on your care and wellness, and let your community know how they can show up for you. Because we need to be able to do this in a sustained way. And I think the current model is set up for people to burn out. So to resist that, we kind of have to change the way of doing business.
So true. Thank you so much, Ms. Fowler. It's been a pleasure. And thank you all for joining. We hope to share this recording with everyone, and drop us any questions you have via email. And again, thank you again. This has been really, really good and impactful.
It's been an honor. Thank you all.
Yeah.
Have a wonderful evening.
Take care.
All right.